At the outset, I would like to express my sincere thanks to both Glenmark Pharmaceuticals and to DocMore for inviting me to give my thoughts and share my views on my approach to a patient with cough, particularly in this pandemic crisis when we are facing coronavirus infection in a very high incidence where majority of the patients present to us with cough and fever. So what should be our approach for patients with cough? I would like to initially mention about the evaluation and then finally talk about the mechanisms involved in the development of the cough. The initial evaluation should include a detailed, thorough history as well as physical examination. Particularly in this era of virtual video consults, it is rather difficult to do a thorough detailed physical examination of the patient, but as much as possible one should try to attempt to obtain physical examination, but a thorough detailed history is of paramount importance. So as a clinician, one should inquire about the history of allergies to dust, smoke, fumes, chemicals or any irritants, particularly industrial pollutants, and also inquire about the history of intake of any drugs, particularly drugs like ACE inhibitors or non-selective beta blockers. Also make a direct inquiry about symptoms of post-nasal drip, and this needs to be ascertained. So we need to ask the patient, do they feel as though something is, when they lie down they feel trickling of secretions into the back of the throat and they have this sensation of clearing their secretions on and off, which is an indirect evidence of postnasal drip. Also inquire about history of GERD in the form of gaseous abdominal distension and acid reflux, particularly in the night time after a heavy meal. Note of detailed history of particularly associated complications related to cough, such as syncope or sudden blackouts, more so in male than in female patients, and history of cough associated urinary stress incontinence, which again is more common in women than in men, and particularly in multigravida women and women who have undergone multiple abdominal or uterine surgeries. They may have this associated symptom of cough related with urinary stress incontinence. Duration is also equally important. Normally, an acute cough, we label it as one which lasts for not more than 3 weeks. So, less than 3 weeks becomes acute, 3 weeks to 8 weeks becomes subacute, and more than 8 weeks becomes chronic. Also, make an inquiry about family history, particularly of asthma or allergies, and also family history of interstitial lung disease. Having done so, if you can attempt to do a physical examination, you may be able to pick up any secretions in the upper airways. Post nasally, you can identify any secretions by asking the patient to open his mouth and then examine the typical pharynx with cobblestone appearance, and that may be evidence of indirect evidence of post nasal drip. You may also be able to identify any mucosal swelling in the nasal mucosa, and you may be able to see enlarged glands in the throat, particularly in young children. There are several etiologies or underlying causes for causing stimulation of this cough. To begin with, the largest chunk is upper airway cough syndrome, and this comprises of both postnasal drip as well as the asthma and GRD. Postnasal drip, I've already elucidated to you just now. As regards asthma is concerned, about 10 to 15% of asthmatic patients, particularly in young children and in adolescents, they manifest only with dry, irritating cough nocturnally, and this is called as the classical cough variant asthma. In addition, one must remember that certain non-asthmatic patients also may have cough, and this is called as the non-asthmatic eosinophilic bronchitis. This is typically characterized by in an atopic individual there is increased presence of sputum eosinophils, there is absence of bronchial hyperresponsiveness. So the methacholine challenge test is going to be negative in these subgroup of patients, and that's how you differentiate the non-asthmatic eosinophilic bronchitis from classical cough variant asthma. In addition, the other common cause would be a post-infectious bronchial hyperreactivity following an upper respiratory tract bacterial or viral infection, and this is one of the mechanisms for development of cough in COVID. Following the viral pneumonia, there will be increased hyper responsiveness of the airways become extra twitchy or extra irritable, and then leads to bronchial hyper responsiveness with cough, which tends to last for at least 6 to 8 weeks. In the present scenario of this COVID pandemic, I think it is extremely important for us to educate our patients not to do self-medication, because if you try to resort to self-medication with antibiotics, anti-allergics, and steroids and whatnot, I have seen patients who have taken three courses of antibiotics and have not responded, and then they consult us for further evaluation of cough. I have seen patients who have been on a fairly large dose of steroids for a prolonged period of time. They don't respond. Only after 4 or 6 weeks, then they seek medical assistance. So this self-medication should be avoided as far as possible. Inappropriate self-medication is dangerous, and it will cause delay in seeking medical advice in time, and it will lead to unnecessarily lot of side effects. And with wrongful taken medication, there will be obvious drug resistance, and therefore cough is a very common initial symptom in all patients with COVID. And I earnestly request through this platform to educate for doctors as well as patients that if the patient develops any of these symptoms of cough, particularly dry cough, they should try to consult the doctor as early as possible. Is there a role of cough suppressants? Very limited role of cough suppressants, but I think as a clinician, it becomes extremely important in the overall management of cough to find out the exact cause of the disease and then treat it appropriately. So different types of underlying causes need to be addressed. So thorough evaluation is extremely important, and self-medication by the patient should be avoided. However, as a responsible clinician, I would also urge my fellow clinicians to write a written plan of action for our patients and give them, particularly those who have chronic allergies, what they should do when they have a nasal blockade or when they have a running nose, what they should do when they develop chronic cough, and what they should do when they develop cough with purulent sputum. So to summarize, there are multiple reasons why a patient may have a cough, and in this present scenario of a COVID pandemic, it is extremely important to give due caution to our patients not to self-medicate themselves, to seek medical assistance as early as possible and take appropriate medication. Inappropriate self-medication should be thoroughly discouraged. Once again, I would like to emphasize that thorough evaluation with a detailed drug history, detailed history of trigger factors which trigger their cough should be elicited, and then appropriately treatment should be instituted for all these group of patients. Finally, I would like to thank DocMort as well as the Glenmark Pharmaceuticals for allowing me to share my views during this pandemic. Thank you once again, everyone, for your patient listening. Thank you.